Welcome everyone. On behalf of the RACGP Queensland, I'm pleased to be facilitating this session tonight, which is what practice owners need to know about telehealth in the COVID-19 environment. This event is brought to you by the Business of General Practice Group, which is a support group organised by the RACGP Queensland faculty that aims to support GP-owned general practice in Queensland. This includes current practice owners, aspiring practice owners, and interested fellows. We are eager to engage with you, our colleagues, and hope to foster a stronger relationship going forward. My name is Tony Bayliss. I'm the chair of the Business of GP Group, as well as a member of the RACGP Queensland Council, and the chair of the Darling Downs and West Moreton Primary Health Network. Along with my wife, Dr. Catherine Hester, I own a practice at Carana Downs, which is between Ipswich and Brisbane. Before we get started in the official parts of tonight's presentation, I'd like to acknowledge the traditional custodians of the land upon which this webinar is being accessed today. I pay my respects to elders past, present, and emerging, and I would like to acknowledge any Aboriginal and Torres Strait Islander people participating in tonight's webinar. In terms of housekeeping, I'll run through some features to make sure you can interact throughout the webinar. You should see the control panel like the image on the right of your screen. If you can see a few icons like the image on the left, please click the red arrow to open the rest of the control panel. The control panel provides you with tools to select your audio options and is also a place to ask questions during the webinar. You can send questions throughout the webinar. We have allowed half an hour for Q&A at the end, but may be able to clarify particular points during the presentation if needed. We may not have time to get through all the questions, but we'll endeavour to answer as many questions as possible. To test this feature, please click where it says Enter a question for staff and type where you are located today and press Send. Now, let's have a look to see where we've got. So we've got some people from Castledine, Bribie, Clontarf, Brisbane, and Wynnum. A lot of people from Brisbane, which is good. Jindalee. So we've got a good variety of people, mostly in the southeast. And that's okay. Jindalee, Upper Mount Gravatt, St George, there you go, that's more like it. And we've gotten up to North Lakes as well. So if you have entered your RACGP number when entering, please stay for the whole webinar because that will allow you to receive 3 RACGP activity points, the 2020-2022 triennium. These were formerly known as the Category 2 points. All right, we've even got Bundaberg and Melbourne and Ingleburn in New South Wales. So it's really good to see a good range of people here tonight. And by the end of tonight's webinar on telehealth in the COVID-19 environment, you should be able to outline which consults are eligible for telehealth, summarise the key considerations for a practice owner with GPs providing telehealth consults, and discuss considerations in relation to infection control in the COVID-19 pandemic environment. Tonight's webinar will consist of 3 sections. The first one is an excerpt from a video prepared by Dr. Todd Cameron, who I think you'll all be familiar with. He prepared it earlier on this month, and while some issues have changed, I think it is still generally very relevant. I think it'll set the scene and give you some background, and in future I'll be circulating through the Queensland faculty page a link to the full video, because that'll allow you to see some of the broader aspects that we won't be covering tonight. And I would recommend that as a good use of your time. The second section is a presentation from Dr. Nicole Higgins, who's also an RACGP Queensland Council member. She's from up in Mackay, so I think she wins in terms of being furthest north. And she'll discuss both her responses to COVID-19 and telehealth in the context of her practice, but also her role in setting up a fever clinic in Mackay. The final section, and I suspect the one that I'll probably get the most out of, is a discussion of Q&A. The aim of the presentation isn't to describe a one-size-fits-all solution for your practice, but it's rather to help you determine how to adjust your practice to this rapidly changing environment. This section is intended to last until the conclusion of the webinar and also feed into the next steps for this group. So I guess it would be reasonable to go on to the first section of the presentation, and that is to play Todd Cameron's video. And as I said, I'll be circulating the link to that video. We have his permission to share it, and I think you'll all get something out of this. So thank you very much, and I'll see you afterwards.
Business. Okay, so throughout this, I think we all have an obligation to continue to serve our communities. I don't have a great deal of confidence in the response at federal level at this point in time. I think that will pivot fairly substantially to the models of care that I think will be successful, but I'm making a big call in this, and of course I may be wrong. There are going to be greater minds than mine working on this, and certainly Sachin and I have worked on this. But let me talk about what I think is going to be important in business. If you are continuing to operate a general practice, then you need to take your corona stick around and put everybody at a safe distance. So that would mean that if everybody was more than 1.5 meters apart and the contact was, say, the normal time for a consult, say 15 minutes, and there was no doctor to patient touch, then if that patient was confirmed COVID-19, it would be unlikely that you would be classified as a close contact. It would be more likely a casual contact, and cleaning the surfaces, etc. afterwards with soap and water would be a wise idea. As I said earlier, I think it's going to be harder and harder to do this in a physical sense, and I suspect that pivoting to a full telehealth solution will be important. You need to protect every member of your team. So reception needs a 1.5 meter space. You need to incorporate contactless payment methods, encourage your patients and your family, and indeed yourself, to set up Apple Pay or Google Pay, where you can do contactless payments. Otherwise, above $100, you're going to need to use that keypad, and you should be focusing a lot on the surfaces that you touch, and minimizing contact with surfaces that have been touched by a lot of people. You'd have to be pretty keen to use a touch screen in this environment, in any environment. So I would remove all touch screens from your workplace. Obviously, you have your personal phone. Do not share iPads in your family unless they're cleaned. Everybody should have their own, or there's a clear process for how they clean them. When I say everybody should have their own, it should be clear who is responsible for one is probably the right answer. I don't mean to imply everybody should have an iPad. And likewise in your workplace, make sure that people work at the same workstation, that when they check in and they check out, there is some cleaning done that means that the environment is safe for the next person. You must obey the social distancing measures in your workplace. I have found I've had to catch my people a lot and say, don't use your fingers on touching anything, use your elbows if you can. Continue to keep a 1.5 meter distance even from your colleagues. It's really important in your workplace. With 40 to 80% of people contracting this over the course of the pandemic, the odds are, of course, that you are going to get it, but it is better that that is asynchronous, so as that your whole team is not taken down at the same time. Whereas if it's caught in the workplace, you're more likely to lose all of your people at the same time for a sustained period of time, and you may not be able to continue to serve your community because the odds are your business will fold. So you need to find a way to work through periods of quarantine for your reception team, for your nursing team, and for your GP team. I'm going to talk to you about some ways of doing that, but the current model for MBS payment does not support anything that I'm about to say. I'm just talking about potential solutions to this problem until a viable solution is created by the federal government. Now, during this period of time, you are unlikely to be doing any of the previously considered high value work. So it's not likely that you'll be doing care plans. You'll probably be doing less mental health assessments. You know, you'll be doing a lot less procedures, of course, because almost anything can wait during a pandemic. And at the end of this pandemic, we'll be doing a lot of cleanup work to get to all of that. But our job is to make sure our team is around, they're safe and they're able to function, and they are able to allocate resources in the most efficient way to serve their communities. That's our primary goal. Okay, so strategy, what do you need to do? Well, in my view, you need to do what the countries that have gone before us are doing, and that is a full pivot to remote services. So as of tomorrow, in our clinic, we will not be seeing patients face-to-face. Every single consultation will be telephone. Once we're happy that we have that basic layer of telephone working well, and that will mean that a GP could be at home, a receptionist could be at home, or a nurse could be at home, and they could still function in the environment that we're creating. All of our doctors are getting 5 days worth of script paper, certificates, pathology referrals, and 5 overnight shipping envelopes to send stuff back to the practice. That is an intermediate stage until we can do everything digitally. But at the moment, we're going to work on a physical process, and you'll see that a lot of rules are relaxed around the way that we currently distribute, for example, prescriptions. And we have been liaising and working closely with our pharmacists to have a viable model for them to be able to safely provide ongoing supply of medicines to patients in our community. So I'm going to get you to put together a Facebook group here. And in your Facebook group will be everybody that works in your practice. Doesn't matter if they're employee, contractor, it doesn't matter if they're allied health, whoever they are that will be part of the solution that we will continue to offer your community needs to be in your Facebook group. Put the nearest pharmacy owner in the group. If you have 2 or 3, put them in there too, because they're going to be part of your responsive package, responsiveness to the community. What we plan to do is we will be dropping our prescriptions downstairs to our pharmacy until we can create a digital solution. The pharmacy will be calling the patients, notifying them of the readiness of their medications. When the patient arrives in the car park, they'll call the pharmacist, they'll pay over the phone, and the pharmacist will take their medications out and drop them through the back window. We'll be asking patients to take the back window and drop it down. The pharmacist can pop the medications in and leave, and everything's done then remotely. We will not be allowing the pharmacist to have patients freely walking around in there. Again, I think this has been poorly done in our community thus far, but I think you'll see that things change dramatically and very quickly. So we're looking out for our pharmacy buddies as well, because we know that our community is going to need all of the services we can offer. We think it's going to be easy to provide probably 90 to 95% of what patients need on the phone, and we'll be able to communicate them via a YouTube channel and via our Facebook page, and make sure you have an internal Facebook group, and that way you can check in on people that might be on quarantine or isolation. You can get regular updates. You can share what's relevant in the group. And look, you know what? It's going to be a pretty tough time. So a little bit of comedy probably doesn't go astray in there when you feel the time's right.
So thank you for that. I've seen from some of the comments, and I agree that there are some issues about what Todd said that may not be relevant for your practice. So when he made the discussion, or when he made the video, for example, there weren't mental health plans that you could do online. So this is a moving feast at this point, and I think we can talk about how we can safely incorporate things like care plan reviews, wound dressings, and immunisations into our practices. So I think the reason we started with Todd is because he has a very clear vision as to how we should respond. It's not necessarily the way that I would respond, but I think it's certainly a good starting point, and I think he's put a lot of thought into it. So while I won't necessarily be coming Todd 2.0, it certainly gives us something to think about. So our next presenter, as I mentioned earlier, will be Nicole Higgins. The reason we've chosen Nicole is because she has a wide range of experiences that many of us won't have in terms of this field, or won't have yet. And I think he will give you some further ideas as to issues that might come up and how you might seek to address them. So with your permission, Nicole, I'll hand over to you.
Thanks, Tony. And feel free to put in the chat box, people, any questions that you might have. I think so my name's Nicole Higgins. I'm a GP in Mackay, North Queensland. So my situation is probably a little bit different from those who are in the southeast corner of Queensland. And I think but that being said, we're all very much in the same place. So I'm thinking about at the moment, where am I now and where do I want to be in 6 to 12 months? How can I make sure that I have a practice that is viable, and how do I keep my employees safe, and how do I keep my employees employed, which is where we are. So my first point is, how do I protect my doctors and my GPs? If I don't have GPs working, then I don't create income. And if I don't have income into the practice, then I'm not viable. So everything that I do is to make sure that those employees are safe. And we'll go into that in a minute. Then the next bit is, okay, so I'm looking after my GPs. Then the next part is to look after my staff, to make sure that everything that I do and all the safety nets I have in place doesn't put them at risk, because that takes me, puts me at significant risk with respect to work cover and all those sorts of things. Our patients always come first. However, if we don't look after our GPs, we don't have any patients. So we want to protect our patients for themselves and also from us. And we need to give the perception that we're caring, because we are. That's what we do. Everything that we do is always about our patients. In the end of this, I need to make sure that my business remains viable, that in 6 to 12 months to 18 months time, that I emerge at the end of this with a viable business that looks after the patients in my community, that employs people within my community and looks after the GPs who have served me well. Then we throw another layer onto it. I need to conserve my PPE, and I'm not sure how many of you are in this position, but our PPE is actually what's defining our business goals. And I've heard stories of, one of our local practices, on one weekend they had one doctor come in, and that one doctor used up all the practice's PPE for the weekend. That weekend for the whole of the pandemic, and we all struggle with it. So where do I want to be in 6 months' time, and where do you want to be? I want to be viable. I want to actually survive. And, there's different forecastings, but 50 to 75% of us will survive, but there's quite a number of practices that won't. Those that won't will probably sink fairly quickly. There's quite a few that will meander along, and there are a few of us that hopefully, when this emerges, that all those patients that have been left behind by other practices, and that is happening because a lot of practices won't see patients who are unwell, will emerge safely. And at the moment, it's like when you jump on a plane, God forbid they're not flying, but we all want to put our own oxygen masks on first. So how do we get there? How do we make sure that our practices are viable? And the difficulty is every time, we turn the corner, there's change, and trying to let our staff know, how do we navigate this? At times, I'm not sure if you're like me, but the anxiety is huge. I'm not sleeping very well. I have collected a local group of practice owners within the Mackay region, and we're all in the same boat. No one's sleeping very well. We're all worried for our employees. We're worried how we're going to navigate this. So our collective resources are really important, and our collective support is probably even more so. So about practice viability, there's a few different ways of looking at this. I'm going to start with the really basic thing that I think most of us are a bit nervous on, and that's PPE. We're using one set of PPE per day. That's it. So we made a decision about 3 weeks ago to conserve what was given, and we keep a total every week. We do a stock take on how much is being used, and it is one person per day who uses one mask plus or minus a gown. And what we were finding is if we didn't have that every time a doctor went out to see a patient in the car park or someone came into the practice, they were donning PPE. So we've organised a pop-up clinic, and people are triaged to that. And that is now a 1 4-hour session. The reason why 4 hours is so important is because if we are to get a PIP payment in the next quarter, we need to either have 50% of our hours or 4 hours per day allocated to face-to-face patient care. Now, with that face-to-face patient care, we've put a traffic light system, so green, amber and red. So green is things such as teleconferences, because that doesn't put your staff at risk, it doesn't put the patient at risk. Amber, these are our essential services essentially. So these are childhood immunisations, these are our excisions, you know, pigmented lesion, a melanoma, things that need to be seen, and these are triaged by other doctors, and there is one person per day in PPE gear, if required, that we strategise through, who'll look after it. Red are all our festy patients. So these are the coughs, colds, snotty noses, fevers, all those things. So they go on to the end of the day after that one person who has stepped up through the process. We'll see. Now, these might be your people who've travelled overseas. These are the patients who are unwell with coughs, colds, whatever. The idea, I'm lucky enough, I've got a separate entrance to the practice. So they come into a separate space, down a separate walkway, into a separate room where we just do, that's by this stage is full PPE. Each practice is different and people will make different decisions. But in Mackay, we've only had 5 cases of coronavirus, and they've all been brought in by travellers. I'm sure, you know, there's probably people, you know, going around in the community or with our FIFO workers. However, this is probably the best way that I can protect my workers. So the last thing that we've done is set up we're in the process of negotiating with a fever clinic. And I don't think this is probably relevant to most of you. It depends where you live. There's been a lot of processes through the government to be able to do it. But what they've based it on is the quality of the care that you give to the patients and the processes and the procedures that you already have in place to ensure the safety of your GPs, your staff and your patients. And if you're doing this well, you know, this is what makes your practice very, very different to the practice who's next door. Ultimately, you want to emerge from this in 6, 12 months' time, having a viable workforce and having the recognition within your community that you care and that you actually know what you're talking about. So thanks, Tony.
Excellent. Well, thank you very much, Nicole. I think what you've highlighted is that the solution you need to make is unique to your practice and to your community. I think while it's a very stressful time, I think it's really important that we remain available to our staff and our community. Reflecting through this whole experience, I think about what it was that made me seek to become a doctor. And part of that was to mean something to people. And while this is a challenging time for all of us, for me, that's where I'm drawing a lot of my strength from. One day down the line, once this is all sorted out, people will remember how we responded and what we gave to our communities. And I think we need to get on the front foot with these challenges. So what I would like to do is I'd like to hand over to Bruce Willett, the chair of the Queensland Council, because he'll be looking after, I guess, the Q&A. I think while he works through what he'd like to talk about or the questions he'd like to answer, I'd just like to talk about my own reflections. So my wife and I arrived home promptly into quarantine. So one way or another, we ended up being the early adopters of telehealth. So basically, the way that the criteria were at the time were because we were in self-isolation, we could see any patient who needed to be seen. So what we did was we got our admin staff to triage our patients and see who could be seen safely over the phone. We've set ourselves the target of between 80 and 90% of patients being managed remotely. Part of that is to manage the PPE, but part of it's also to manage just staff wellness and safety. It's really weird because we have full books, relatively speaking, but we have empty waiting rooms, which is a strange experience. What this has meant is we do spend a lot of time from an admin perspective. There seems to have been a shift away from using our nurses to more using our admin staff to check that we've got the right phone numbers, check that people don't need to come in, and things along those lines. So we've had issues or challenges where we've had to change our processes to match that demand. The other thing that we found that's quite difficult is telecommunications. So we actually have a variety of ways that we seek to engage our patients. And one of the challenges related to that is making sure that our forms of communication are encrypted. The other thing is that we also have to look at how we communicate with our pharmacies, and we're actually spending a lot of money on postage at the moment. And so I think we've got to look at our processes for delivering scripts to pharmacies, because if we're paying $1.10 every time we send a script to a pharmacy, we'll actually end up, well, not necessarily getting to financial difficulty, but I won't enjoy paying for it. One of the other strategies that we have is we actually keep some appointments available at the end of the day for those patients who we've spoken to over the phone who actually need to be reviewed in person that day. So basically, you might have a patient who you see, who you do a telehealth consult on at 9 o'clock in the morning, and you're not comfortable to manage it without them being seen. So then we'll get them back in the afternoon session in person once we're happy that they're safe from an infection perspective, but also once we realise that it would be high yield to see those patients. I see that there's a question about flu vaccinations, and one of the strategies that we've got is we are running a flu clinic, but it's actually through our ambulance entrance, and we've got seats parked 1.5 meters away from each other for patients to sit and get their flu shot, which is done by our nurse. So there are a variety of options or strategies that your practice may or may not be able to use. But what I might do now, if it's right with you, Bruce.
Sorry, everyone, I forgot to unmute. Can you hear me now? So I'm Bruce Willett. I'm the Queensland Faculty Chair of the RACGP, and I'd just like to thank you all for coming along. I would hope that this is the first of a number of events that the RACGP organised to better support people who are practice owners and people who with an interest in owning practices. I would like to encourage those who don't own practices to consider owning practices, because I think it's really important that we control as much of our work environment as we possibly can. I also would like to develop this into a format where we have more and more interaction and more collegiate support of one another over time. And I'd like to thank the people who've been putting in questions and also the suggestions. So I noticed that, so one of the last ones was that Christy noted that that they actually do telehealth interviews with or consultations with their patients before they come in for a face-to-face consultation, and that's something that we certainly do in our practice as well. So we've gone to doing as many telehealth consultations as we can, but some patients are electing to come in and make face-to-face consultations, and we are actually screening those people first with a telehealth consultation. We've had a discussion in the practice that there may be some risk about that, about billing the patient twice, and Cully's already noticed that. And so usually those telehealth consultations are taking place in the morning and the patients are coming in the afternoon, and we're currently billing them as two separate items. And we're finding that that is working better. And there's basically two reasons for doing that. One is because a lot of patients are not used to the concept of telehealth and don't really have a good concept of what things can be sorted out as a telehealth consultation equally and what things that can't be. So it's a way of reducing the number of people entering the practice. But the other thing is also the risk stratification of patients. So like Nicole, we are running a fever clinic of sorts within the practice. So more worrying patients who may have something infectious are being seen in a dedicated clinic. They are also entering the practice through our ambulance entrance, and they're waiting only one or two at a time outside that entrance under a little marquee we've set up in the car park, like I've noticed Simon has done as well. And they're also, 2 meters apart. So again, we've got one person in PPE gear seeing all of those patients. And those patients are screened out through the rest of the practice to be seen in that environment. There was certainly, there was also questions about flu clinics, and we're doing those. Fortunately, we've got an empty building nearby, an empty shop nearby, and so we're actually doing them in there. It's a concrete shell, and we've bought some screens and put chairs in there, and we're doing them there, doing them in lots of 5, so people come in, sit 2 meters apart, and there's we call in a couple, and then we call in the receptionist organise the next 5 to come in. They're having to report to the reception desk first, and then pay for the private flu script, and then they go down and we give them the injections. There was a question from Peter earlier about different platforms, and I'm just wondering what platforms people have been using for their face-to-face telehealth consultations. I wonder if people might pop that into the chat box now. If you don't use any video ones, just put telephone. But for the others, if you're using Zoom or Skype or FaceTime.
I'm interested to hear other people's opinions on this, Bruce, because I've tried various different things. So I've used Zoom, I've used GP Connect. I'm in a regional area, so my NBN can be a little bit haphazard. I've found that I've actually had to use multiple platforms because what works one time doesn't work the next. Is that other people's experiences? I think one of the difficulties, and actually one of the joys out of all this, is phone calls with my patients. I've found out a lot more from having a chat, especially my elderly patients, and having a chat on the phone is something that they're very familiar with. And to have their GP call them is deemed to be something very special. And so don't underestimate what we do. I think the younger patients are probably a little bit more comfortable with video consulting, but maybe not so much our older ones.
Yeah, and Zoom and Skype has the advantage in that it has encryption that meets the criteria for health, whereas I'm not sure about whether or not the free version of Zoom is fully encrypted. But the problem with Skype is, you know, arranging that consultation is much more difficult. I wonder, is it possible to activate the mic for some of the people who are using, someone who's using GP Connect or one of the other services, and some of the other ones up there that are I've not heard of, like AutoMed systems, and if they could just, if someone could, that's Peter, if we could talk about that and how that works for you. Doesn't look like that's possible.
So I've tried using GP Connect. I think it's probably a system that may or may not be overwhelmed. Maybe it's just my experience. It looks very, very simple from a patient point of view. My only concern with that is they haven't actually said how much it's going to cost in April. So once we're all on this system, how much is it going to be for me as a practice owner? And the difficulty at the moment for me, I've got all these other bills coming in, and yet to have another one, to have another platform could be a bit hexy.
So there was a question from Rebecca about, Nicole, where you got the information about the 50% face-to-face consultations. So I saw the same information that you're required to have 4 hours a day of face-to-face consultations. And I've seen that a couple of places, but I can't remember where I've seen it. Can you?
That's been released through government websites. It's been released through the MBS and RACGP. So what it means now that if we are to claim that second part of the PIP, so it'll be based on December's PIP, that we must either do 4 hours per day of face-to-face patient contact, or 50% if you're a part-time practice. Now, what that means in practice is, you know, do we have to bill a certain item numbers? Do we have to say that there's X amount of number 23s, or our traditional face-to-face numbers? I'm not quite sure how they're going to police it or whatever, but what they're trying to do with this, and I do have some discomfort with it, is to ensure that there's no exploitation of traditional general practice.
Yeah, I suspect the policing of it in the initial phases will be light. But I think it is a responsibility for practices to offer some face-to-face consultations. I think while we're all trying to do as much as we possibly can by telehealth, there are some things that really do still require face-to-face, and I think it's a reasonable move, and I think it stops you know, people just setting up call centres that really are not offering the full suite of services to general practices.
And I think the biggest risk to patients at the moment is probably not COVID. It's the fact that their heart disease or their diabetes or their domestic violence issues aren't being dealt with in general practice. So it's still really important that we still offer that, you know, that service that makes us really good at what we do.
Yeah, and so in some ways the the little excerpt from Todd in the beginning is a little bit misleading in that he made that when this first started to happen, and I think he was trying to spur the government into doing some things to get things working a little bit earlier. So there was questions from how does Todd do his flu shots and things, and he has 3 practices. He's closed 1, and he's continuing to offer face-to-face consultations in his other 2 practices. So I think he was deliberately overstating his case in that video. He has, and we are in our practice transitioning to reduced face-to-face hours in our practice and in increasing the telehealth hours. So we're going to only be open physically from 10 to 4, but we will open for telehealth consultations from 7 to 7 and have the phones manned over those periods of time. So trying to, again, reduce the exposure for the staff, for the nurses, for the doctors, and allow people to be more vigilant for a smaller period of time to make everyone a bit safer. I've lost track of the questions. So we've got Rod on the podcast now. So Rod's the Deputy Chair of the Queensland RACGP. He's also a Willet, but he's not related. Rod, what are you doing in your practice?
I think one of the things that strikes me a little bit as important and an issue is non-essential services, and one of those are things like IV vasectomies, for example. And I have actually heard word that if we are to perform non-essential services such as vasectomies, we may not be indemnified by our indemnity insurers because that has been declared as non-essential. So I think that's an important thing. I mean, obviously, as practitioners, we need to show some leadership in this area of what's essential and what's not, and the protection of our patients. But there may be some more implications on that as well.
That's a good point.
I'd actually say you're an essential service, Rod, because in Malaysia they've closed down the biggest condom factory in the world. So I would actually say you're an essential service.
But that also includes things like skin cancer services. And I know the Skin Cancer College has also issued some directives on what is considered essential and non-essential. So asymptomatic screening of skin cancer patients is probably not acceptable. Follow-up of a melanoma patient is probably acceptable. You know, you've then got the issue of at-risk patients at risk of coronavirus, but also at risk of skin cancer because they're immune suppressed. I mean, they're all quandaries, aren't they? They're difficult.
Mm. So Peter's made the point that you know, video is essential for some services, that you do just need to eyeball patients, things like trauma and respiratory distress, and that AutoMed system is fully integrated to best practice and MD, which makes it worth looking at. Sounds great. And James has made the comment that the full subscription to Zoom is only $20 a month, and that's also perhaps worth looking at.
Bruce, I think our Brisbane South PHM has offered some subscription to some form of video conferencing as well, which may or may not be available yet, but I haven't looked into it personally. But as a practice, we've decided to stick with simple telephone. We've felt that the video link is not quite so important at this point, as we can still see patients if we need to. But the PHNs might have something available. Yeah. It looks like ours does.
So I'm looking at this webinar at the moment. There's 4 of us on screen, and Bruce, I hate to tell you, but you're quite pixelated, and which may or may not be a good thing. And I'm with Rod. You know, good old-fashioned telephone actually cuts the mustard most of the time. And I've learned so much about my patients just through a telephone chat. It's actually a really intimate experience. And I don't think we should actually underestimate what we do on a telephone consult, especially our older patients.
And I think there's some data. Somebody mentioned in one of the questions about, you know, a professor somewhere talking about telephone conferences are actually very, very effective. And that's certainly what I've heard too. I don't have resources or references to people, but I have to say it's worked very well for us. And if I need to see something, I've got patients that are actually taking photographs with their smartphones and emailing them to me, and that's actually worked quite nicely.
Yeah, I remember reading a report somewhere where psychologists got people to hear an audio of someone telling a lie, and they had to pick a lie from a truthful statement, and watching the video of them doing the same thing. And the interesting thing was that when it went from audio to video, the perception of the accuracy of detecting lies actually went down. People were more likely to be distracted by the visual information. So perhaps it'll make us all better listeners. Certainly for the majority of my older patients, I find that they are preferring to do telephone consultations, and the younger patients are often preferring to do the video conversations. There's a question about chronic disease management plans. So we are moving to actually have our nurses go through and work on doing those with our patients, and then involving the patients in those at the end of the process. And that, as far as I can see, does seem to be permitted by the MBS.
I was going to say, Bruce, this is actually a really important question about our nurses, because they've been a big casualty of this, and there are a lot of practice nurses that are now finding themselves unemployed. And how can we utilise our nurses? Because we need to position ourselves about what happens when we emerge out of this crisis, and we will need those practice nurses. So we need to actually employ them to be doing duties and tasks that actually profit the business. So I know I'd value your thoughts.
Yeah, look, I think the APN has reported that there's already been lots of nurses that have been made redundant in this process, which I think is very sad. And most of the majority of the work that nurses are doing is now, not available, because most of what they're doing is physical, hands-on stuff. So I think it behoves us all to look for creative ways for nurses to do, things. And I think care plans are one of those areas where they can become involved, and we can maintain them as long as possible. So my nurses, so it's funny, and one of the things is just re-educating all of the staff to think a little bit differently. Certainly one of the struggles that I've had with receptionists, for instance, is that they will take queries and then want to shuttle backwards and forth to the doctors, as they usually have, and trying to educate them to say, no, just find a doctor and put them through, and because that's now a billable item. And the same with the nurses. They wanted to produce a list of care plans with a view to making bookings for them to do them. And so I said, no, produce the list of people who are due for care plans, and actually just ring them up and see if it suits them to do it now or some other time. And so it involves some unpleasant cold calling for the nurses, but I think it's a much more efficient way of doing it. And so it's all about not just having new systems, but doing that transition to a whole new way of thinking about the way we do things in the practice. And it's a cultural change that we're going to have to make and probably unmake again in 6 or 12 months' time, which is going to be difficult.
So I'm a training practice, and one of the things that I've had to pivot on is that it's not my nursing staff, it's my registrars who are the people actually making the decisions about triage. And instead of, Joe Blow rings and they want to know about their medication and blah, 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 blah. So it's actually the registrars who are making those decisions. So it gives obviously income into the practice. It makes that consultation or that conversation meaningful. But ultimately, it's what makes our practice viable. So we actually do need to change the way we think about every phone call that comes in, every contact that we make with a patient, so that we can, come out the other end of this.
What I was going to say about our nursing staff is, firstly, we had a med student from the UK who came over, and what they do in the UK is the nurses will actually look at the day list and talk to the patients before they come in. So I think we could certainly use the skills of our nurses clinically to work out who needs to come in versus who doesn't, to look for any landmines and things along those lines. But the other thing we're doing is we're trying to involve our nurses more actively in the flu clinic to give them more responsibility. I think Nicole made the point that, you know, these people are going to be with us in 6 months when hopefully this all settles down. I think it's important we show loyalty to our staff where possible and try to find roles where they can add value. And I think the challenge for us is how we reallocate our resources, you know, in the COVID-19 world.
I must admit, sorry, Rod, I've given my staff the chat, you know, as a practice owner. You need to be with me on this. You need to trust that I have the knowledge, which I may or may not, to actually steer this practice through this to get us to the other side. And you're either on board or you're not. And if you can't, this is now the time to step off. But if you're with me, you're in there, you know, boots and all, and it's going to be uncomfortable. It's going to be really difficult at times. But as a practice owner, my world is going to be 10 times more difficult than yours. But I can't say that. I can't tell them that. I just have to be that voice of calm to steady the ship.
I agree with you, Nicole. I think you mentioned, I don't know if it was online or offline, about your huddle with your practice. I think that team spirit and that camaraderie between our staff, that's our reception staff, our nurses and our doctors, is really vital at this time.
Great.
So there's a question about billing for the care plans. So yes, so we're having the nurse do them and basically organising them, and yes, the doctor then has to ring back and make sure that and just check off with the care plan to organise the billing. So essentially, we're mirroring the same processes that went on in the practice before telehealth in a telehealth environment. There's been some questions about consent, and my understanding is that verbal consent is sufficient. I can't see how it can be done any other way in a telehealth environment. And the other thing that the health department are very concerned about is just making sure that privacy is ensured and that you check that it's the right patient. So you're in theory at least still required to have the 3 points of, you know, ID, so check their name and, you know, phone number and date of birth, you know, just to make sure you have the right patient, and check that they're able to discuss these issues in their current environment, that they feel safe. So the things that we're perhaps not used to thinking about because those things are generally taken for granted in a face-to-face consultation. There was also a question that I'm going to take on notice about how to conduct the patient satisfaction surveys in preparation for reaccreditation. And Nicole,
Yeah, so we contacted QPA about this exactly today. They've said to us that we can still proceed with accreditation and that they will hold over our practice surveys. So that's all I can give, and that was QPA. It wasn't anyone else. AgPal, thank you. But don't stress about it.
Yeah. The other thing, and I'll ask a question of the collected wisdom. Has anyone got official notifications about over 75 drivers medical yet? are patients still required to do them? It's obviously going to be a very uncomfortable thing to ask someone over 75 to come in and have their vision check, you know, for a relatively administrative thing like that.
So I gave a 3-month, sorry, my dinner's just arrived. I gave a 3-month holdover for a patient today. So,
yeah. I was wondering if we could send them to the optometrist for their vision checks, but as of today, the optometrists around me are closing down, so that's not going to work either.
I guess what I find, Bruce, is we're all in the same boat. You know, nobody's actually got an answer, and we're all sort of scrabbling. So, you know, I had a commercial driver's license today, which, you know, I'd recently seen. So I had enough information to know that they were safe and that they were going to be safe for 6 months. And so I gave them a 6-month interim medical certificate. That's the best I can do at the moment. And it's not going to be 12 months. They're going to have to come back in 6 months. But ultimately, I need to protect them. I need to protect you know, myself as a clinician, but also the community.
Yeah, look, I've heard, but not had it confirmed, that there will just be a moratorium for people with those conditional licenses. But I just wondered if anyone had heard it officially. That, yeah, and someone said that that's what's happening in New South Wales, and I suspect that's what's going to happen in Queensland. And in some cases that's going to be scary, because there's those patients that you go, this is your last license, you know, you're on a restricted license, you're no local driving, no night driving, and you won't get it again next year. So they're going to score another 6 months or a year out of us, which might be a little bit scary. I don't know whether other people do that, but it's certainly something I do to give patients a period of time to adjust to not driving. The other thing that's been discussed is tonight is the prescriptions, and I must admit, so we're like Tony, I was doing the you know, $1.10 mail out of all the prescriptions, and so then we started bundling them up, and so we're going to do it once a fortnight. And then some of the chemists complained about that, so I said that's fine, you can now come and just pick them up. So we're not mailing them out at all. So it was just getting out of hand. Everyone's probably aware that the government's fast tracking the secure electronic exchange of prescriptions. So that's been something that's been in the pipeline for, I was trying to think about it, it was about 10 years, I think, you know, since those MediSecure and eScript acts started appearing on our computers, and that was with a view to having secure electronic script exchange roll out then, and just nothing's come of it. So that's supposed to come out within the next 3 weeks, supposedly, and that will solve both the pharmacists and ourselves a whole lot of pain.
So I'm talking about being in a regional area, so I'm not quite sure how well this will apply into urban spaces, but we've given our local pharmacies, you know, a copy. They know who we are. They actually know who our signatures are anyway, but a copy of our digital signature. And so for those who are working from home and having to email, they can match up the digital signature with those that have been emailed in. Or the other option is, you know, this is one of the utilisations of making sure that as a training practice, my registrars have meaningful work, that they're, you know, countersigning any prescriptions that are coming through to make sure that whether they're referrals or scripts, pathology, radiology, etc., can be countersigned. So I think we just have to be really lateral in how we do things.
Yes, so one of the things that we've done for the doctors working at home, I've configured a single printer to print all the prescriptions, and the doctors are just signing each other's prescriptions and pathology requests. So they're still in their name, but they're just countersigning them for them. So that works really well for everything, except of course for S8 scripts. And you know, I think it's really for S8s that the doctor prescribing it really needs to sign those. The federal and state health departments have flagged S8s of a particular area of concern, and it's an area that they'll be watching very closely, that doesn't go out of control with the telehealth, and it's certainly an area which I think has a potential to go bad, and something we need to watch.
Now, can I make another suggestion? It's one of the tricky things, you know, you don't want to be chasing patients, but patients still want to know that you care. So we're doing a rollout of actually starting with mental health first, and then we can roll out to diabetes, COPD, etc., and just going through our chronic disease groups. And it is that, for example, Dr. Rod is just checking in. Dr. Rod would like to know how you're doing through this. If you want to have a chat, please click X and book a telehealth appointment. And I think, and we're doing that through our software, and that's not going to cost us anything more, but it's just a way of making sure that we keep our patients engaged and doing it in a way that's quite ethical as well.
Bruce, can I ask a question? And this follows on from a statement made by Harry regarding telehealth. I mean, he talked about the responsible use of telehealth and that the opportunity this might give us as general practitioners down the track to, you know, even go forward with this when this coronavirus situation is finished. I just wonder if it's worth just talking to the group about, you know, as a group being responsible for our telehealth claiming and making sure that this isn't seen as an abuse, and we may have an opportunity down the track, which is really quite important.
What can I say other than yes? I think this is very much seen by the college as an opportunity to establish the viability of the telehealth role. It's something that the college has been pushing for now many years, to have some recognition and ability to charge for the time that we spend on the phone with patients and doing the sorts of things that we're now doing much more easily. So yes, and at the end of this, I think we're all hopeful that there will be an ongoing telehealth item. I think patients will get used to it and like it and demand it, and it's certainly something that we would like to see continuing. I think realistically, it's probably not going to exist in the same sort of format, and it'll probably be for, you know, reduced populations of patients, and it'll probably be for more the sort of older and patients with chronic diseases. And of course, the thing is that it may well be linked to you know, some sort of blended payment model. I would hope that it still continues as a single fee-for-service item. But it is, of course, really important that we use it responsibly and use it in a way that enhances experience for patients. Because the other thing at the end of this, the government's going to end up with a huge budget deficit, and they're going to be looking for ways to claw back money. And if we provide them something that's too easy, then that's not going to be very good for us. Oops.
Actually, that's a good question. We discussed today cervical screening, and we didn't come up with a unified solution to that one. Does anybody have any comments?
We're just putting it on hold.
Tony?
We're putting it on hold unless they've got high risk symptoms, and then they're stratified green, amber, red. But it probably is something that we can put off for 3 months, 6 months. Oh, starting to feel uncomfortable.
Yeah.
So we talked about the one up unannounced and untriaged as being a doctor optional. So, but otherwise we agree with that.
Yeah, we're not pushing it.
The other group that's difficult is the colonoscopy recalls, because most of the gastroenterologists aren't doing them. So again, those patients are probably more at risk from a potential bowel cancer than they are from coronavirus in most cases. So making sure that they don't slip through the cracks, which is an unfortunate turn of phrase, but we're just going through and actually, as they come up, and resetting their reminders for 6 months time, and the admin and staff are just putting a note into the patient's notes as to why that is.
One thing that I think is interesting going forward is I wonder if eventually I assume this will be rolled back to one degree or another, but I do wonder if this will develop a market amongst some of our patients for telehealth going forward. So I think telehealth as it is an opportunity once this is over for us to have developed an appreciation for patients of the convenience of it. So I do wonder if, and that would, even if it's fully privately billed, I do wonder if there'll be patients 12 months down the line who do see a value in what we do, but find it physically difficult or inconvenient to come in, who would like to, who'd like to do this going forward. So, I think general practice has been stagnated in terms of funding for a while, waiting for the government to decide to pay more for the same thing that they've been getting all along. And I think it'll be interesting if we can develop experience and establish in our patients' minds the view of the value of telehealth. I wonder if down the line that will be a way that we can, I guess, increase our private billings outside of the Medicare context. So I'd be interested to see what people have to say, but I think there'll be an opportunity for us as well.
So going back a little while, I can't remember who noticed it, but someone said they rang up Advant and said it was okay to countersign pathology forms, but not prescriptions. It's a discussion that we've had in our practice. To be honest, we know that we're bending the rules, but we've decided to do that under the circumstances, and so it's with the consent of all the doctors that they know that we're sailing close to the wind. And but in terms of trying to keep patients as safe as possible and provide the best services we can, it's something that everyone's consented to do. And I'd make the same point of the same thing. We're aware that doing the telehealth consultations and then following up with a face-to-face consultation later in the day may at some stage earn us the ire of the MBS and Medicare, but we feel that it's certainly under the circumstances well and truly justified in terms of providing maximal patient and staff safety.
I was just going to say, Snehal Patel mentioned a BMJ infographic that really helps you to structure a telehealth consult. I'll be sharing that tomorrow in the faculty council, in the faculty links that I'm going to share. So I'd recommend everyone have a look at that, because I think it'll help you to understand the different aspects of a telehealth consult that you might want to think about incorporating. Sorry, Rod.
So you're talking about the Queensland Faculty Facebook page?
Yep. Yeah, I'll put through some things that I came across when I was preparing this, and it'd be interesting to see what people think of it.
I was just going to say, I'm sorry, Tony, just on the scripts issue, our local pharmacy has actually said that they will accept scripts that are unsigned emailed from us at this time. I don't know the legalities or logistics, but that's what they have told us.
I think it very much depends where you live. I've got relationships with our local pharmacies as well. Same with pathology, same with radiology. So as long as we all know what we're doing, what I was really surprised with this week when we contacted Queensland X-ray, Mackay Radiology, Q-Scan, they actually didn't have any procedures in place for electronic referrals. And that was a little bit scary. And so we led the way within our local community, and now they've all actually come back saying, you know, we've got online request forms, we've got this, that, and the other. But the large companies have not done this, and it's general practice who's leading the way. Now, I can't see the questions. Is there anything else that people have got any burning questions on that they wanted answered?
Just to finish up, is there anything that others are doing in their practice that they feel it's working really well that we could learn from?
I can tell you all my boo-boos.
I've
I've made a few.
Yeah. So before you do that, so Peter said that many practices have collection centres, and we've got one nearby. And certainly for patients, we've actually moved to a model where if patients need COVID testing, we leave them in place in our rooms, and they come to us to do them now. So that saves contaminating 2 rooms, one in their place and one in ours. And one of the good things about telehealth is now that we've got spare rooms, we never used to have spare rooms, so we can rest rooms and decontaminate them. Rod, can you see the questions?
I can.
Do you want to pick some? Why don't the pharmacists pick up the script at the end of the day? Well, we have them doing that.
We have the same.
I think the hardest thing for me as a practice owner is actually looking after my staff. And it's looking after their mental health well-being, it's keeping them in touch. So having a huddle every morning, I've changed our practice hours, so we've actually reduced them. So I actually had a group of staff who were working 4 days a week. I've now had to stretch that to working less hours, but over 5 days. We have a huddle every morning. We've now got synchronized times. We touch base every day. There is an email only about what's changed, not what is, but what's changed in the day. What I found that our practice staff are not as adaptable as what we are, and trying to bring them along with us is really difficult. However, one thing that they do have is I've reassured them that they have a job and that they're safe. And if they do and ask, and if they trust in what we're doing, then they'll be okay. Anyway.
The big thing I've learned is telehealth consult. If they don't answer the first couple of times, you just move on to the next one and call them back. You can find yourself getting bogged down with trying to contact people, but it can be quite difficult to catch up. The other tip is we haven't submitted our billings to Medicare because the updated bulk billing incentive hasn't come through yet, and some of the new on best practice, and some of the new telehealth item numbers, the equivalent for a mental health plan, for example, isn't through. So I guess I just be conscious of that tomorrow when you're submitting when you're batching off your consults, just to make sure you don't get shortchanged. that's kind of the main thing that they're the main things I focus.
There's a really good question here because it's a problem. So we also meet every day and have a big chat about what's happening, and it's been a really important thing to involve the whole practice and the decisions and where we're going. But there's a question there about how do you social distance, because I've noticed that we have really strict social distancing in our practice all the way through, all the time, except the lunchroom. And it just all falls apart in the lunchroom.
Very question.
Yeah.
And the lunchroom, it is actually big enough, but there's only kind of one table and everyone just still sits together and communicates together. And I think it's because there is a sense of being, quite close. It's a bit more like family than it is like being with a group of strangers. And so all the social distancing stuff seems to fall away. But sorry, yeah, Rod and Nicole.
I was just going to ask Nicole how she huddles with social distancing, because our meeting today was very much like yours, Bruce. It was in our tea room, which is reasonably large, but there were a few people there, so it probably wasn't ideal.
No, so we all did a bubble. So we all twirled around with our arms out, made sure we had our bubble in actually our waiting room. And then I had a teaching session today with my registrar. So we went for a walk outside because there was only two of us. We went for a walk to the local park. So you can do things just differently. You just need to think outside the box a bit.
All right. Well, I might wind things up there. Look, I really enjoyed I've really enjoyed, talking to everyone and hearing what Nicole's doing, and to be honest with you, while things have changed, I think Todd's best bet 2.5 weeks ago wasn't too bad. One of the really enjoyable things about practice ownership is that you do get to dictate your future to a degree. At times like this, it's really, it can be really threatening and stressful, but I do know that there's good that will come out of it. At the Queensland Council of the RACGP, we're really eager, as we said earlier on, to engage with practice owners, aspiring practice owners, and just our colleagues. So what we'd like to do is to continue the discussion with you. So what I'm going to do tomorrow is I'll share the links that I talked about earlier on to the council page. What I'd like, if it if it would suit you, is I'd like it if you could actually talk about things you learned or things you do differently, but also if you want to post to that chain resources or strategies that you found that would be really useful. I'll also give you my personal email address because I'd like to try to keep things going. So if there are any issues that you'd like us to bring up or address, or if you'd like to be involved with the business of GP Council, please let me know. We appreciate your time. You're all very busy. So if you do need to contact me, my email is acbayliss@hotmail.com. So that's acbayliss@hotmail.com. And I look forward to hearing from you. So thank you for attending tonight. Thank you for your time. And we look forward to seeing you again in the future. So thank you very much.